Good evening, friends. It is indeed a great day for CAHO. Historically, I'm sure 1st December must be remembered for many things, including, for example, in 1963, Beatles came to America for the first time and sang their solo song, Let Me Hold Your Hand. And of course, you know that 1st December is celebrated as the World's AIDS Day. But in the history, whenever it will be written for CAHO and for ISQua, it will be for starting our international webinar series. This is a real milestone for us. This milestone is to really tap into the global experience of quality and knowledge and bring it to this entire country of ours and the adjoining countries. We are indeed thankful to Peter Lackman, the CEO of ISQua, for making this collaboration happen and to start this, I would say, collaboration of the international. So every month, we will be coming to you with one expert from across the globe. And therefore, I would say it is to enhance our knowledge and to share their experiences, which will be really beneficial to each one of us. We are indeed, in fact, also very fortunate that the president of ISQua, Dr. Ravindran Jagasoti, is today present with us at this occasion. We are indeed, because we have a great relationship with ISQua, which is going very strong, and we really are, sir, humbled by your presence here.
Thank you.
This series, sir, we are really looking forward, and therefore I'm not going to take any more time. What I'm going to do is to request Dr. Lalu Joseph, our Secretary General, to introduce the first topic and the first speaker, Eyal, Zimlichman, but leave it to Lalu. Please do the honors.
Good evening, friends, and it's my proud privilege as Secretary General of CAHO to introduce our speaker, Dr. Eyal Zimlichman. Dr. Zimlichman serves as Deputy Director General, Chief Medical Officer, and Chief Innovation Officer at Sheba Medical Center, which is Israel's largest hospital. Many hats, sir. Previously, he held the position of Lead Researcher at Partners Healthcare's Clinical Affairs Department. Dr. Zimlichman has served on several advisory committees at the US Department of Health and Human Services and is chairing as well as participating in several committees at Israel's Ministry of Health. He is also a founding member of the International Academy for Quality and Patient Safety. Dr. Zimlichman is the founder and director of Sheba's ARC Innovation Program, which aims to redesign healthcare through digital health solutions by 2030. He is board certified in internal medicine and has completed a degree at the Harvard T.H. Chan School of Public Health and has earned his MD at the Israel Institute of Technology. We are honored to have him deliver his thoughts on patient-reported outcome measures. How did we choose this topic? Because this is a new requirement from our accreditation body, and this is something new for our country. So we want to hear from Dr. Zimlichman and start our journey with patient-reported outcome measures. Over to you, Dr. Zimlichman.
Thank you very much, and I'm extremely honored to speak and also to be the first speaker on what is looking to be a very successful program. And I wish you a lot of success in this in the future. And I'm also very honored that you've chosen PROMs as the first topic to focus on for your program. And of course, very happy to hear that it's part of the accreditation process in India. And definitely needs to be on the table of many accreditation bodies around the world. The work I'm going to describe to you actually started about 12 years ago when I started working on PROMs in Boston at Partners Healthcare. And I'll take you through some of the questions we had back then when this all started. About 12 years ago, nobody or very few people knew about the word PROM. It's not as it is today, obviously a much more well-known word in some countries, even I would even say a buzzword. So I'll take you through that journey and then to what we've built at Sheba Medical Center in Israel, where I'm currently the Chief Medical Officer and the Chief Innovation Officer. So let's start our journey, and I'll try to leave us some time for questions towards the end, because I'm sure that this will bring around a few issues you would like to ask. So there's a new healthcare paradigm. The patient is looking for the best achievable and sustainable outcomes for him, while the healthcare systems are looking to achieve affordable outcomes that matter to patients across the continuum of care. And one of the first questions at Partners Healthcare in Boston, which is the network for the Harvard hospitals, we asked ourselves when we started dealing with value-based healthcare, one of the main questions we asked was, what are the outcomes that matter to patients? What should we as healthcare providers need to focus on if we're looking to be the best we can in those specific outcomes, the outcomes that matter to patients? And we'll talk about that, of course. So we're talking about the need to maximize value, and we'll say in a word what value is. We're talking about the need to provide patient-centered care. We're talking about the need to provide personalized medicine. And of course, we're trying to do as much comparative effectiveness as we can to try and understand what provides the most value for the lowest cost. Critical, of course, as we move into the future where healthcare costs are always, of course, rising. Well, when I think about these four critical topics, I find that patient-reported outcomes are right in the middle of all these four. And I'll try to describe to you in the next minutes why I think PROs are critical if we're going to achieve these four elements. So again, this is a slide that goes back to my early time at Partners Healthcare, I think 2008 or 2009, when we started thinking about the care we're providing patients. And the idea was to provide care that is valuable to the patient at a cost that is appropriate. And when you talk about value for patients, we're looking at two issues, of course, outcomes in relationship to the cost. So the outcomes need to be defined by the patient, measured for patient's condition over the entire episode of care, while the costs need to be measured for the patient's condition over the entire episode of care as well, whether it's cost to the system or cost to the patient. At the end of the day, when we're trying to focus on outcomes and we're talking about value for patients, then patients would appreciate value when the outcomes are outcomes that matter to them. And this is the whole idea of value-based healthcare. Many times we substitute the outcomes by outcomes that we are focusing on: readmissions, infection rates, pressure sores, and so on. These are the negative outcomes we're trying to avoid. But the patient is foremost interested in the positive outcomes, in what he stands to gain by receiving therapy. You will agree with me that at the end of the day, the patient is much more interested in what are the chances he will receive the benefits of the treatment, rather than what are the chances that he would actually have some kind of complication. First of all, it's what we intend, rather than not what we intend to prevent. And at the end of the day, it's all about value. And Professor Michael Porter, who was my mentor in Boston from the Harvard Business School, has said this the best, I think. The central goal in healthcare must be value for patients, not access, volume, convenience, or cost containment. It's not that the others are less important, but what Michael Porter says, he says that if we focus on value for patients, then the others will take care of themselves as well. So we need to focus on value for patients. And he also says that healthcare systems need to be redesigned so that they dramatically improve patient value. The whole system needs to revolve around how do we constantly measure and improve the value we provide to patients. And at the heart of this, of course, is patient-reported outcomes. So what would be outcomes that matter to patients? Let's have a couple of examples. Hip replacement patients. We see a lot of those, of course. You know, hip replacement patients are interested in mostly in the functional status, maybe also the level of pain that they have in the knee, in the hip. Are we measuring now functional status for hip replacement on every patient as part of routine care? Probably not. Maybe as part of clinical trials, but we're not doing that as part of routine care. What is a patient who's undergoing cardiac surgery interested for? First of all, functional status. He wants to be able to do things he cannot do now when he has a coronary disease. And of course, he's also interested in survival because cardiac disease has much to do with survival as well. Are we measuring functional status for patients undergoing cardiac surgery as routine care today? Probably not. What do patients with cancer, what are they interested in? Of course, survival is foremost on their mind, but not very far behind survival is quality of life. We know of these cases of cancer patients who are saying, you know, I'm willing to trade quality of life for survival, but many of them are saying, I'm not willing to make that trade. And so quality of life needs to be measured, needs to be improved as we try to improve what we're doing. And diabetes, I would say also it's quality of life, because it's easy for us to ask the patient to inject insulin 3 times a day and take glucose tests 6 times a day. But what's the toll on the quality of life? What's the toll of hypoglycemic events on the quality of life? What's the toll of multiple medications that they need to take on quality of life and on eating maybe much less than what they would actually like to eat? So the quality of life for diabetic patients is critical. Are we measuring that as routine care in diabetes patients? Probably not. So these are the outcomes that matter to patients. And that brings us, of course, to patient-reported outcomes. And the definition, the clear definition of patient-reported outcomes is information about the status of a patient's health condition that comes directly from the patient without interpretation of the patient's response. We don't have a healthcare practitioner that interprets what we think the patient is saying. We have the patient report it directly to us. And these would include typically symptom level, like pain, for example, functional status, both physical and mental, and health-related quality of life. And we'll see some examples in our next slides. So to measure that, we need to use tools. We actually need to use standardized tools and validated tools. At the heart of PROMs are PROM tools. And these are some examples of PROM tools for different purposes. EQ5D, the EuroQual, is a quality of life tool. 5 questions that we measure quality of life for patients. So it's a generic tool. We can use it with any type of patient, whether it's a cardiac patient or a cancer patient. We want to measure quality of life, we can use the EQ5D tool. But there are also disease-specific questionnaires, like the HUS and KUS for hips and knees, specific questionnaires developed and validated for patients undergoing hip replacement or knee replacement. There's the Kansas City questionnaire for cardiac patients. There's the PHQ-9 for depression. So these are all are disease specific. Others like SF36 or SF12 or some of its variations are generic. I want to say a word about PROMIS. PROMIS is a very important resource for PROM tools. It's a program that was initiated by the NIH in the US, launched in around the early 2000 years. And if you log on to the PROMIS website, and I urge you to do that, you will find hundreds of tools that are all free to use, all very highly validated and calibrated, so that you could actually, and many of them are also translated and validated in different languages. So it's a great resource to look for what you're actually looking for both the generic and disease-specific PROMs. So why PROs? We said some of this already. Why is it important to measure PROMs? Why accreditation bodies should embrace this? First of all, we're measuring the intended consequences. It's quite incredible to understand that healthcare so far has been focusing on the unintended consequences, focusing on what we're aiming to avoid. But what about focusing on what we aim to achieve, focusing on what we aim to provide the patient with? And I think, each one of you can think about this. Why are we so reluctant to measure what we intend to achieve? I think it's a very interesting conversation. We could follow up later on in the questions if anybody wants to. We're looking at value as seen by the patient. Remember, there is no interpretation by the healthcare practitioner. It's value as the patient sees it. And as we look at consumerism and the importance of what patients are looking for, how they see the value they receive is critical for us to take the next step into the future healthcare system. We're looking across the continuum of care, because how the patient is doing on quality of life or functional status, it does not really relate to one provider or the other, but looks across the continuum where many providers could play a role. It could be a primary care physician, but obviously the surgeon and the physiotherapist, they all play a role in how we're doing after joint replacement, for example. So it's a clear opportunity to measure across the continuum of care, and many times we're missing measures that assess the continuity of care. And I think in that regard, PROMs answer to this very nicely. It also supports accountability, because if I am accountable for my patient's results, if I'm accountable for the patient to feel better, if I'm accountable for the patient to have a better quality of life after a hip or knee replacement, then I need to measure what I'm accounted for, both what I intend to avoid, but also what I intend to achieve. So this supports accountability, which is of course important. And also it has many, many other additional benefits, and we'll see that during the presentation. Patient activation, comparative effectiveness, transparency will drive value, research on many, many levels. So it has very wide benefits as we look at it. Let's start with an example. I think it'll be easier for people to understand what PROMs are and what they can be used for if we start with an example. And the best example to start with is also probably the oldest example. And that is maybe the first use of PROMs in a structured program that was also, of course, published a lot and so on. And this is at Dartmouth Spine Center in Dartmouth Hitchcock Medical Center in New Hampshire, one of the leading institutions now pushing quality of healthcare and value forward in the past 20, 30 years. And some of the people you see here, from James Weinstein, William Abdu, and of course, Eugene Nelson, who's really one of the forefathers of modern PROMs and a dear friend that we work a lot also in ISQua relating to PROMs. So this is what they've done at Dartmouth. This is a spine center. They're doing mostly spinal surgery, but not only surgery. They also treat conservatively patients with back pain. And this goes back to the year 2001, where patients who came into the clinic were handed a tablet. You see the tablet here in the photo. This is how tablets used to look like in 2001. They were very bulky, heavy. You had to use a stylus pen. It's not the iPad we have today. But again, just to think how pioneering this work was 20 years ago. And you see here what the patients were doing. They were answering questions relating to history and symptoms, risk factors, disability status, patient perception, functional status, and so on. And the doctor received a report, like the report you see here, that had all the information on one view and could tell me the functional status of my patient using the SF-36 in this example, also looking at this longitudinally, and also where actually the patient was showing pain. You see here on this scheme, the patient is drawing exactly where does he have pain on different intensity of pain by different colors and so on. And this report is one of the earliest reports that actually puts on one view the value that patients see and what they actually are looking to achieve. And the patient perception is critical. We might get back to this example later on. But then they had another use for this data. They also looked at the aggregated data on many, many patients and have shown averages on their website, for all of their patients and all of their visitors to see. So if I'm a patient at the spine center at Dartmouth, I can log online and I could see, and again, this goes back almost 20 years. So remember, internet even wasn't that popular these times. I could compare 113 surgical patients to 53 non-surgical patients on body pain. A high score is better. So in this regard, surgical patients had better scores in terms of pain than non-surgical patients in a follow-up of up to 1 year, real-world evidence. This is not a clinical trial. And the same for physical function. High is better over here as well. The surgical in red provides better functional status than the non-surgical. So if I'm a patient and I have back pain and I come to the clinic and the doctor would tell me, listen, one option would be to do to do surgery. Another is to do conventional therapy, physiotherapy, and so on. Why don't you log online, look at the results, and use that in your decision-making on what is the best treatment for you. And I think you would agree to say that in terms of decision-making, shared decision-making, this is a great tool for patients to use to base their decisions on. So what are some of the uses of PROMs? Why should we measure and use PROMs? We see about 4 buckets of uses. One is, of course, outcome monitoring, starting from the left here. I want to monitor the outcomes of my patients on an individual level, but also on an aggregate level so I can learn from it. I also want to measure symptoms and track symptoms. I won't talk too much about that today. I don't have time to cover everything, but this is a whole different idea that I track symptoms once every week or once every 2 weeks, for example, for patients undergoing chemotherapy or patients with chronic conditions, and I react to what the patients are providing in terms of, for example, a spike in pain or starting to complain about constipation or about nausea. I could react in time. That was shown to actually improve survival even for cancer patients, and there's publications around that. Shared decision making, I already shared an example. We'll see another one. And precision medicine, again, I won't be talking too much about that, but aggregated data on PROMs can help us tailor a specific treatment for a specific patient. It has to do with big data. It's more advanced use of PROMs once you've gathered a couple of years worth of data. Again, I won't be talking about that today because of lack of time, but happy to follow up at a later time. Let's see an example from Martini Clinic, looking at outcome monitoring. Martini is an integrated practice unit specializing in prostate cancer in Hamburg, in Germany, of course, founded in 2005. For those of you more familiar or less familiar with integrated practice unit, the idea is a multidisciplinary team centered around the patient, providing a home for the patient for a specific condition, in this example, prostate cancer. And one of the central issues in IPUs is being able to track and constantly improve outcomes. And PROMs, of course, play a critical role. Look at the volume of prostatectomies done at Martini Clinic compared to some of the big names in the world. They're doing twice as much as Mayo Clinic, twice as much as Johns Hopkins. You see some of the other names. So huge volumes. And if you have huge volumes, you have a huge opportunity to measure and improve all the time. And this is what actually happened at Martini Clinic. Frequency of continence, 1 year post-radical prostatectomy. I'm sure you know one of the major complications after prostatectomy is continence, urinary continence. And what we can see here on one end is the volume of radical prostatectomies going up throughout the years, but also looking at the percent of continence. And of course, we want to be at 100%. Look at the percentage, typically below 80 or around 80. But then when they started measuring frequency of continence as a patient-reported outcome, and providing the reports back to the doctors started using the information on an individual basis to improve their outcomes. And you can see how outcomes have risen above 90%. And you'll see this in the next slide, where we're comparing Martini Clinic to the average in Germany and the average in Sweden for 1 year full continence. Look at the data. In Martini Clinic, 93.5% after 1 year have full continence, urinary continence after total prostatectomy, while the average in Germany is 56%, and the average in Sweden is 50%. Look at 1 year severe erectile dysfunction at Martini Clinic compared to the national averages, and 1 year severe urinary incontinence, where we're showing smaller numbers, but in Martini Clinic almost does not exist. And this is a clear indication of the success that Martini Clinic has done by measuring PROMs and providing PROMs for the clinicians to constantly improve their outcomes. Let's see another example. This is from Partners Healthcare. I mentioned that I worked with Partners for about 5 years, and I was leading the effort back then to build the PROMs platform for Partners, which is now one of the most advanced PROMs platforms in the world. And this is something that you can see right now at Partners. If you're a patient, you log on to the patient portal. You see here they actually changed their name a couple of months ago to Mass General Brigham, but this is from about a year ago. And when you go in and you want to see how patients are doing, for example, after total knee replacement, this is something that every patient can see when they log on to the website, in terms of looking at pain, relief from knee pain. So we want the score to be high, of course, the percent of patients who are free of pain. And you can see time 0 is the time of the surgery. We're seeing an immediate improvement in pain in the first 120 days post-procedure. Then we're still seeing some improvement, and then very little improvement going on after about 250, 260 days post-surgery. And this is important for patients to see. If you're a patient who is about to undergo total knee replacement, one of the major questions you're going to ask is, when will I feel improvement? And half a year later, after treatment, will I still see improvement going on, or have I reached a plateau in terms of my improvement? And you can see how this is being projected to the public for Partners Healthcare in Boston. So let's jump from these couple of examples to what we're doing at Sheba Medical Center. And there are many, many case studies I can share, but I wanted to focus on what we're doing at Sheba, and start by describing in a few words Sheba Medical Center, Israel's largest hospital, about 2,000 beds, acute care hospital and the rehabilitation hospital and the children hospital on the same campus under one management, where I sit as the chief medical officer, academic medical center, research and innovation powerhouse. And it was ranked as number 9 in the world by Newsweek in 2020, out of about 2,000 hospitals around the world that were ranked. We're very, of course, proud of these achievements coming into the top 10. So before I dive deeper into what's going on at Sheba, I want to share with you what we've learned from the Partners Healthcare experience from the years I've been working there. And this is very critical for anybody who wants to launch a PROMs program. I call it this attributes of a successful PROMs program. Let's start with number 1, to make patient-reported outcome instruments actionable for care redesign. They need to include both a generic tool as well as a disease-specific tool. And I gave some examples before on what is generic, like PROMIS 10, EQ5D, SF36, and so on. There are generic tools, while disease-specific measure outcomes specific for a condition or a disease, like some of the examples I provided. You want to be able to measure both. If you're doing, for example, PROMs for knee replacement, you can measure the CAHO, which is specifically for knee, or the Oxford tool for knee, and one of the generic functional tests. It's important so that you're able to both compare your patients within the patient population with what is related to a knee replacement, but also you might want to compare patients across different conditions. And so a generic tool will allow you to do it. Number 1 is to ensure PROs would be used to improve care on both patient-specific level and on a population level. We need to reach a response rate of at least 60% of the target population. So if you have 1,000 patients a year that undergo knee replacement, you want at least 600 and even 700, if you can, of these patients to report back PROMs, so you get a good estimation of how you're doing with the population at large. And I'll give some pointers later on how to achieve this very high response rate. Because typically, if you don't have concrete interventions, your response rate is going to be similar to the response rate we're seeing with patient satisfaction surveys, which is typically around 15 to 30%, very far from 60 to 70 that we need to achieve. The third is a multimodal electronic data capture approach should be utilized. You'll see what I mean in a few slides. And the idea is I use electronic data capture from a couple of different options, and I offer the patient the option of how he would like to report the data to me. And it needs to be near real-time reporting, so I can use the data and feed it back to the doctors. We'll talk about that. We'll see examples. Providers need to be able to act proactively on trends of PROM data. So eventually data needs to be integrated into the electronic records. And this is, of course, critical It's not always easily achievable, but today we're seeing this in many, many countries, that the large electronic medical record companies are providing PROMs, whether it's integrated or they work with another vendor to be able to introduce that into the electronic record. Patients should have access to patient-reported outcome data. So the data is not just for us as providers. The data is very important for the patients themselves. We need to be able to provide them the data. The best option is through a patient portal electronically, if you have a patient portal. But even if you don't have a patient portal, it's important to, even if you're just able to print the report in the clinic and hand it by hand to the patient, that is very important, and I'll come back to that point later. Patient-reported outcome data integrated with other value metrics, because they are not the only value metrics, should play an important role in evaluating and comparing treatment modalities and services, both within the organization and for benchmarking outside. So for example, it's not just about PROMs. We still need to continue to measure infection rate, continue to measure readmission rate, continue to measure mortality rate where it's applicable, and so on and so on, continue to measure process measures. All of those are important, but PROMs are a critical element in the full spectrum of outcome data and process data as we look at value metrics. So this is what we're doing at Sheba. This is the multimodal data capture approach. The way to collect data from patients needs to provide as much flexibility as possible. Remember, we're trying to achieve 60% compliance, at least. This is going to be very, very challenging. So we need to offer, in the best case scenario, multiple options. Some patients will fill this out in tablets while they're waiting in the clinic, or even with pen and paper in the clinic. That's always the best opportunity, because you have them as captured audience. They're typically waiting, they have time to spare. You're giving them a tablet, you're saying it's important, you collect the data. But that's just in the clinic. What happens outside of the clinic? Much of the data collection happens outside of the clinic. Then of course, mobile phone applications are critical, because obviously everybody carries a phone. Patient portals are critical. If you're using the desktop, you can provide the data through the patient portal and view the results through the patient portal as well. And if all else fails, phone operators who call the patients to collect the data is the last resort, because some elderly population might not be using mobile phones or desktops and will need to actually call them up. So human phone operators is the last resort. This is something that we have to achieve, if all else fails. Here's an example for coronary artery disease. We've been collecting data at Sheba for more than 5 years now on cardiac surgery patients, intensive care unit patients, step-down units, internal medicine wards, patients that come in with coronary artery disease, acute coronary artery disease, or even if it's non-acute. We collect the data pre-discharge in the hospital, facilitated through computerized evaluation using a tablet. The patient is in his bed on the ward. He receives a tablet, fills out the PROMs, but then when the patient is discharged, we follow up 30 days, 3 months, 6 months, and 12 months follow up to see how the patient is doing across time. So we have very close to the event, pre-event, or directly after the event. If it's an acute event, obviously, we're not going to stop a patient with ST elevation MI coming through the emergency department and say, wait, you need to fill up PROMs, but we will give him the tablet after he has gone through the procedure and ask him to fill it out based on his situation before the procedure. This is how it looks like on the tablet. Of course, it's in Hebrew, but also I wanted you to see how it looks. Very large text. It's important, of course, because we're aiming at a very wide range of patients. Some of them are elderly, some of them have sight problem. You want them to be able to read it. When you're at home, you can receive an email that asks you to follow a link, and then you would fill out the questionnaires at home at the specific time points we have decided on. 1 month, 3 months, 6 months post-procedure, and it would be different for each procedure, the timelines that we are asking these questions. Of course, it's very easy to do this at home. You fill out the questionnaire after you follow the email that you receive at the proper time, and the same goes through an app on the smartphone where you can fill up the answers on the app, and you get a notice that it's time to fill out the PROMs, you know, at the time that was set ahead of time. This is our electronic medical record. Again, sorry for the language, but everything obviously is in Hebrew, or most of the things. But you see here, currently we have all the PROMs reports in the electronic medical record. You see in a second how the PROMs report look like, and we're now upgrading to a new system. So by next year, we'll have a much upgraded platform here. And this is how the actual report looks like. And this is, for example, for coronary bypass surgery. And you can see here we're measuring for patients who have undergone bypass mental status, functional status, chest pain, shortness of breath, quality of sleep, and sexual function. And then in the report, there's a short explanation here to the patient. What do we mean when we say mental status, for example? There is this color-coded accelerometer that shows you where you are currently, and you see the dial is pointing towards the green area. So of course, that's very easy for patients to know if they're doing well, or if they're in the yellow, or of course, if they're in the red. And then we also let you see how you're doing across time. So if I give you an example, let's go to functional status, for example, which are second row here. You see right now that the functional status was lower pre-surgery, which is the first time point, stayed the same for 1 month post-surgery, because we know these patients 1 month post-CABG are still very limited, but also already 3 months post-surgery, there's an improvement over the baseline in functional status. And then 6 months post-surgery, there is an ongoing improvement. So you could actually see what is the value that the patient has received from going through CABG bypass surgery, just by looking at functional status. It's the actual value received for the procedure. And we can go down and look at chest pain and shortness of breath and see the improvement on shortness of breath, improvement on chest pain, and so on. So this is one way to look at value. Let's look at foot and ankle surgery. This is actually an athlete that had to go through foot and ankle surgery. We're looking at mental status, functional status, pain in daily activity, and ankle function, all through, of course, standardized tools. And look at the ankle function pre-surgery, where high is good, of course. We always have this arrow here on the left that is pointing towards high is good or low is good. It changes from metric to metric. And as you can see here, 1 month post-surgery already improved ankle function, and improvement is still going on to 3 months post-surgery as well. And you can see the other metrics here. These reports would be the same reports that doctors view through the electronic medical record and the patient views through the patient portal. So what we're urging our doctors to do is bring this up on their computer on the desktop, turn the screen towards their patient, and have a discussion on the results of the surgery. And many times this type of discussion provides so much benefit to the patient and improves the communication and the decision-making and so on, that we find it to be a very, very important in the dialogue. Let's see some examples of what we can do with the data. Let's look, for example, on coronary bypass surgery outcomes by gender. Just look at the physical function, baseline 30 days and 90 days. You can see, first of all, there's a big difference between women and men, which is, of course, not something that we typically talk about a lot. Red is females, blue is male. You see the physical function is higher in females, 35 versus 20 on the PROMIS 10 score. And you can see the improvement across time up to 90 days for physical function. For mental status, again, you see the status here between men and women. For chest pain and shortness of breath, what's very interesting is that men had more chest pain than women, but because of the surgery, 90 days later, they look very, very similar. There isn't a difference between men and women, and the same goes for shortness of breath. Again, male had more shortness of breath than females, but again, this was leveled as we look at 90 days post-treatment. Another way is to compare surgeons or surgeon groups. Let's look at cataract surgery outcomes, physical function, mental status, visual function, and reported vision. And we could compare between group 1 of physicians to group 2 of physicians. This could be 2 hospitals, this could be 2 clinics to hospital systems, whatever we want to compare, and we can see that on visual function and reported vision, there wasn't a significant difference between the two groups, which is always better politically, of course, than when we have to deal with big differences. Implementation status at Sheba, we're now at about 40 different clinics and conditions where we're collecting PROMs data. We started, as I said, 5 years ago, and we launched the first ones, which were prostate cancer, coronary disease, and cataract, but now we have much more. And the typical response rate varies by condition. So for inflammatory bowel disease, we have very high response rates. These are typically younger patients. They work very well with electronic means. And you can see we have more than 80% response rate. Breast cancer patients, around 60 to 70. We typically see higher response rate for cancer patients because cancer patients are much more invested, as I say, in their conditions. Of course, when you have cancer, you're very much focused on trying to heal from cancer. Of course, it's something that's top on our minds more than cataract surgery, for example. And typically people tend to do what we ask them to do. If we ask them to fill out PROMs, they will do this. So a 60 to 70% response rate. Cardiac surgery a bit lower than that. And lowest was the cataract. Again, the more your patient is invested in the condition is a big part of his life and he's focusing energy and time to dealing with it, the better chances you have of getting high response rates. But the challenge would be to get high response rates with conditions like cataract, for example. So what are the challenges? Well, I think you can already imagine. First of all, it's getting patients to report. How do I get those high response rates? It's the number one challenge. But not much different is getting clinicians buy-in so that they use the data. When we started PROMs about 12 years ago, I was sure number one here, getting patients to report would be by far the biggest problem. But I soon understood that number two here, the getting clinicians buy-in, is also a big problem and a big challenge that you'll see in a second how we're trying to approach. But what we've done is learning from Dartmouth and their implementation at the Spine Center, working with G. Nelson, is coming up with this approach of what we call feed-forward feedback approach. The feed-forward feedback approach says your patient is going to feed forward information to you if you feed back to him what he needs from you. So if the clinicians report back the reports, if the clinicians do the shared decision-making, if the clinicians use the data with their patients, or even if the clinicians are just saying to the patients, listen, it's very important for me that you fill this out so I'm better able to treat you. If they get that kind of feedback, they're much more likely to provide us the data forward. And so the feed-forward feedback approach says, focus on the feedback, the feed-forward will work itself out. The way we're trying to achieve this, as written here, the real-time automated reports, the patients get the PROMs report automatically in real time. So once they finish on the tablet marking the answers and they click end, they already get a report waiting for them on their patient portal that they can view the reports that you have seen, and that provides them with the feedback automatically. Discussion with clinicians, as said before, and even as we look into where we're going with this, patient-reported outcome dashboards for patients. It's not only the doctors that want dashboards, patients, many of them also want dashboards, and this is how we're going to put everything on one picture for them to see, and PROs, PROMs will play a central role in that. With time, we've built the PRO conceptual framework for implementation. This is version number 2, based on the experience in Boston and the experience at Sheba. We've built this framework. I won't go through everything here because it will take some time, but really start from a development phase, move to a pilot phase, and then to a system-wide rollout. In the development, you have to choose the tool design, define target population, resolve clinic-specific workflows. How am I going to hand this to patients? And do the IT implementation. Even if you don't do the IT implementation straight away, it's something that you need to put some effort in. You need to identify the real incentives, why your doctors would want to use this, why would patients want to use this. Sometimes It's a hidden incentive we need to uncover. And you need to involve staff in development. The staff really hate when you come to them and say, use this, right? They want to be there from time zero when you're starting to think about what am I asking, who's my target population, and so on. In the pilot phase, critical to identify champions, to provide continuous usability data, always on your percentage of compliance rates, for example. Build this into clinical decision pathways. For example, if I get a high result on the PHQ-9 for depression, what do I do? What's the pathway for a patient that just tested high on his depression score? If you don't build this into pathways, it'll be much more difficult for the clinicians to use. Alert thresholds and mechanisms. When do I want something to be brought up to my attention as a clinician? It's something you have to build in as well. Discuss in staff meetings. It has to become this language in staff meetings. I want, the paradigm shift is when we're not only discussing the chest x-rays, we're not only discussing the ECGs, we're not only discussing the lab results. We have PROMs that play a central role just like everything else. And just like I won't be able to evaluate a patient without seeing his labs, I won't be able to evaluate a patient without seeing his PROMs. And for this, it has to become the language. It has to be discussed in staff meetings. Develop case studies to actually show the value. Gradually building physician buy-in, it's a process that takes time. And once you're at a certain point, you can go to system-wide rollout, where you're building this into patient-reported outcome measures, like we're doing now at Sheba. You're building this into population health, looking at aggregate data over populations, enhance value to patients and clinicians, and benchmark within and externally, where you're starting to compare between hospitals and saying, if we're doing less than the other hospital in terms of PROMs we deliver, what does the other hospital doing? What is he doing differently that I can learn from him and improve my outcomes? This is the ultimate goal. I want to be able to see where I need to improve and learn from others. What are the best practices around so that I can continuously improve my outcomes? And there are many examples for that, which I won't be able to share with you today, but this is the highest level you want to reach. This is the outcome-based approach paradigm shift. And it's a paradigm shift. The whole process from development to system-wide rollout easily can take 3 to 5 years, depending on the maturity of your system. A couple of last things to mention before I turn it over to questions. Number one is, there are a couple of I would say organizations out there that look at international data. One is the International PROMs Collaborative that I have started, which are institutions that actually are further along in implementing PROMs, getting together and changing best practices, ideas, and so on. This is something that was started when I was in Boston, and it's very live and kicking still, with more and more institutions coming on board. And the second is ICHOM. Some of you might be familiar with ICHOM, the International Consortium for Health Outcome Measures, came out of Boston as well, Harvard Business School, and Karolinska Institute in Sweden. And ICHOM is really dealing with setting standards so that we can hopefully implement it much easily and in the future maybe benchmark. This is an example of what ICHOM is doing. This is from their website. They have all these conditions you see here and much more. This is just an example. And when you go into each one of those, you get the actual information. What are we going to measure, for example, for hip and knee osteoarthritis, from acute complications of treatment, mortality, readmissions, to disease control, pre-operation or revision, reoperation, or revision, need for surgery, treatment progression and care utilization, and patient-reported like pain, physical function, work status, health-related quality of life, and overall satisfaction with result. And there's a specific timeline which tells me when to ask. So begin data collection, then collect every year in this example. But of course, ICHOM has this for each one of those conditions that they're now following. And they typically also publish it in the professional literature, because the idea is to make this be a part of routine care. It's not something that only certain people do or certain organizations. We want this to be the main stem, the regular care that we provide patients everywhere. I'll end with two quotes. One is Theodore Billruth in the 19th century that said, the famous surgeon that said, soon there will be a time where our scholars and colleagues will not be satisfied with general comments on surgical quality outcomes. Instead, they will call any physician a charlatan who is incapable to quantify his results. And this is exactly what we're handling. And the other is Ernst Kodman from Boston. The common sense notion I propose is that every hospital should follow every patient it treats long enough to determine whether or not the treatment has been successful, and then to inquire, if not, why not, with a view to preventing similar failures in the future. And I agree, I hope you agree with me, that it sounds so natural and so logical, and still most of us are not there yet, when this is obviously a big part of where we need to be. So I'll stop here. Thank you very much, and happy to answer questions.
Thank you very much, Dr. Zimlichman, for that wonderful presentation. Let me begin with a feedback from Dr. O.P. Saxena. Excellent presentation in a very simple language. I think that's very apt. So there are a lot of questions. For next 10 minutes, shall we take up some questions, Dr. Zimlichman?
Sure. So do you want me to go through it by...
Shall I read them out for you, some of them?
Sure.
Yeah. So this is from Alicia. Thank you for the excellent presentation. Which PROM would you recommend to use in pediatric cancer patients?
Well, of course, we need to be more specific. When we talk about pediatric cancer, obviously we need to decide which cancer we're focusing on. And then the second thing we need to look is, what do we currently have in the literature? And it can go to, you can search on PubMed or anywhere else using PROMs. You can search, not even using PROMs, because many clinical trials are using PROMs without calling them PROMs. These are the tools that are in clinical trials, and many of them can serve us for PROMs. And of course, it's critical to always look at what ICHOM is suggesting and maybe what PROMIS has. So these are the resources I would go through to make a decision, what am I using for my specific use case. And it typically takes some time. We want the clinicians on board to be part of the decision-making on what we're using. We want people that are more specialists in PROMs to be part of the decision-making, but it's a conversation. We make a decision and we move forward.
Perfect. This is from Akio Hirata. Thank you for that great presentation. I think the PROMs surely improve patient engagement. And I wonder if the feeling or sentiment of engagement itself might affect largely to the outcome of the care. Is there any study on this?
Well, I'm not familiar with these types of studies, but there are many, many types of biases on PROMs. And it's something that's important to note. For example, if the provider himself, and I was asked this yesterday from somebody in Switzerland, if the provider himself is reading the PROMs questionnaires to the patient and fills out the patient's answers, we get a bias tending towards better results, as you could imagine. And the same goes even when we have a phone operator calling the patient up. There is better results when we have a human asking the questions than when we have the patient answering either on a piece of paper or electronically. So these biases need to be taken into account when we design our PROMs program. So specifically, when we have these discussions with patients, we know that they would also impact outcomes. It's not that you cannot do this, but you need to be aware.
Yeah. So this is from Martin. I'm from Uganda. How do we do PROMs in LMIC with poor health systems? Data systems are majorly paper-based and patients do not have access to digital mechanism. How would we get feedback on their outcomes? They also move long distances to healthcare centers. I think this is similar to the Indian situation as well.
So it's a great question, and one that in ISQua we've started dealing with lately. So for a few years, we had these PROMs workshops before the main ISQua event every year. And maybe 3 years ago, we started splitting it into low and middle income countries and high income countries, because there are different, of course, focuses for both. But the main message is PROMs is easy to do even in low income countries, because you don't need electronic systems. You don't have to have an electronic medical record. You don't have to have tablets. You can do PROMs with paper and pencil. It's much like checklists, and why the WHO has chosen pre-surgical checklist, as you're all familiar with, as the one intervention that every hospital in the world, regardless of the situation, needs to implement. Because you could do it in an electronic medical record, but you can do it on a piece of paper. It works just the same. PROMs can be done with a piece of paper. PROMs can be done through a very simple app. And low-income countries, of course, we know that there's a big usage of mobile phones. I know in India specifically, and in many places in Africa. So if you use the technology that you have, like mobile phones, or even if you use pen and pencil, you could get a long way with PROMs and get to results which can be superior to what others are reaching in high-income countries. And again, we're talking in that workshop about that, and I'm sure that if there's need within your community to go deeper into this issue, then ISQua would be happy to arrange maybe a webinar or a virtual workshop to allow you to grab some more tools towards implementing in low-income countries.
Perfect. I'm just going to try and couple few questions. I feel there are many questions on whether you will need to adopt a validated tool or you could develop your own PROMs. What's your feeling, Dr. Zimlichman?
Another great question. We're all tempted to develop our own, right? It's very tempting for us. You can do that. There are a couple of limitations. One is you will never be able to compare because no one else will be using your tool. So if you're thinking about comparing down the road, you want to use a standardized validated tool and use one that obviously maybe ICHOM has recommended or PROMIS is using or some of these other international communities, because you have a higher chance of finding others that do the same. This is number one. Number two is, we know that if you are not doing the proper validation, different patients might understand differently your questions and might answer differently. So you're getting into the validation of the actual context of the question. What might seem very easy for us, understandable for us as healthcare practitioners, a patient might understand something different. So we do content validity as well to make sure that patients understand what we actually want to ask them. Otherwise, we get results on something else. So it's important to follow these few steps.
Yes, I think even context validity may be a little important with these validated tools to make them very, appropriate to the context is something that we need to think through. The validation of these tools, the validation of the data is another question that many seem to ask. How reliable do you need to validate the data that you are collecting? How do you do that usually? Is it some samples that you take? Yeah.
Yeah, it's a classic accreditation question, right? Validating your quality data. And you can do this with PROMs just as well as you're doing this with your other metrics. You can validate a sample. You can validate on different levels. If this is something that your patients are reporting, you can make sure that what has been logged by the patient is the same data that is later on taken into your database, that there aren't any changes or manipulations with the data as you move forward. It's very difficult to, of course, validate with the patient, because we're not going to ask the patient to fill this out again. So you're limited in that regard. But validating data in making sure that when you go through different stops with the data, you go through the traffic of data, that you're not losing some of the numbers or the numbers are not changing, is something that you could randomly look for.
Thank you. I think there are many questions on, can I have some PROMs on cancer patients and some on OBG, pediatrics, neonatology? Are there free PROM tools available? If you could share some resources for us, that we can start with.
So I shared two I think are the most important. One is ICHOM, and each one can log on to ICHOM. You register yourself. It's free, of course, and you get access to more than 50 different conditions that are already on ICHOM. And if you're looking for one of those conditions, you could just take what ICHOM is doing as is, no more arguments. It's the simplest approach. Sometimes ICHOM has too long of a tool, so they would ask you to ask 60 questions of patients. What we've done in the research is we found that you want to try and keep it under 30, the total number of questions, if you want to maximize your response rate. So if ICHOM is saying 60 questions, what I often tell people is try to see what you can skip. Not everything that ICHOM has set is relevant for you, for your cause, your needs. So try to skip a couple of the tools and try to minimize it so you're less than 30 optimally. So ICHOM is a very, very important tool, and it's growing with time. The other one is PROMs. Again, it's free. It's a huge endeavor. The US government has put a lot of money into PROMs. They have validation in different languages. And I think now they have more than 400 different tools there. So you could mix and match, and some of them are computer adaptive testing where you're using just a small fraction of the questions. And it's a logic tree where depending on your answer, you go on to the next question rather than ask all the questions. So it's a huge advantage to be able to use PROMs. And if they have in your language, then of course it's a great resource.
Thank you very much, Dr. Zimlichman, for that excellent presentation and for the answers. I now hand over to Dr. Vijay Agarwal to do the honors. Over to you, sir.
Thank you.
So, thank you. I'm sure that we all agree our opening batsman has been like Virat Kohli for all those who understand the language of cricket. And before I'm again very thankful to Dr. Ravindran Jagasoti to be a part of this. Sir, would you like to say anything at this juncture? You have to unmute, sir.
Yes, that was a very excellent opening innings, as you say. It has set the stage for improvement of the quality of care. And what better way than using the patient himself or herself? I think this is one very good example of patient-centered care, using the patient to tell us how well we are doing, and also to compare ourselves how well we are doing. I think that's the beauty of this PROMs. And because you have got so much of experience in it, I think you have been an excellent presenter for this particular topic. So I enjoyed thoroughly this presentation. Thank you, sir.
Thank you. Thank you, Dr. Ravindran. And so therefore, we, of course, conclude this session by also announcing that our next webinar will be on January 5th at 5 p.m. again. The topic will be incident reporting, analysis, and building the culture of safety by Dr. Shin Ushiro, who is the professor and director, Division of Patient Safety at Kyushu University Hospital, and director, Japan Council of Quality Healthcare. So I am sure that Dr. Shin will also lead to, I would say, this continuing series of excellent webinars, which are going to, I will say, really benefit all of us in this part of the world by getting global perspective on various aspects of healthcare quality. So thank you very much, ladies and gentlemen.
Yeah,
thank you very much, Dr. Eyal and Zimlichman.